Good evening, everyone. Welcome to the August chapter of this Therapeutic Forum of Sri Lanka College of Internal Medicine. Today we have Dr. Ruwanthi Jayasekera with us as the speaker. Uh, Therapeutic Forum was introduced by the SLSIM to enhance and upgrade the knowledge of practicing physicians around the country, and to enhance the practices and knowledge, we have been asking speakers from respective fields to update us regarding the novel practices and the knowledge. Without further ado, let me invite Dr. Krishanta Jayasekara, President, Sri Lanka College of Internal Medicine, to address the gathering.
Thank you very much, Ranga. So I think, as Ranga very correctly said, so this forum was initiated about 2 years back, and we have invited many specialists in various fields to share their expertise with us, because we manage patients with multifaceted diseases. And of course, it's very important that we, embrace the expertise of many specialists whose input would be extremely important in managing these patients. So obviously we know there are many NCDs, and we are burdened with NCDs and obesity. The sleep-related disorders have become a major burden to us. And of course, there are very many advances in sleep medicine in the recent past. So I think I'm really thankful to Ruwanthi for accepting our invitation. So and I'm pretty sure this forum will be really eye-opener to many trainees as well as internists who have joined today. So without further ado, may I invite Dr. Anga Gunasekara to formally invite the speaker and proceed with the webinar. Over to you, Ranga.
Thank you, sir. Dr. Ruwanthi Jayasekara, Senior Lecturer and Head Department of Pharmacology, Faculty of Medicine, University of Moratuwa. And she's a consultant respiratory physician, MBBS, MD Medicine, MRCP, and ESRS, and she's an expert somnologist. She has obtained accreditation in sleep medicine from ESRS, that is the European Sleep Research Society, and have been conferred the title Expert in Sleep Medicine in 2020. And she's competent in polysomnography, respiratory polygraphy, as well as in managing all types of sleep disorders. Let me cordially invite Dr. Ruwanthi Jayasekara for her lecture. Just before that, I just have to tell some ground rules to the audience. At the end of the lecture, we will be sharing a QR code so that you can obtain a ministry approved accredited CPD certificate, and there'll be a QR code which will be appear, as well as the link will be shared in the chat box. In the meantime, as the lecture is going on, you can ask your questions using the chat box or from Q&A, and we will be taking up those questions at the end of the lecture. Dr. Ruwanthi Jayasekara, over to you.
Good evening, and thank you very much, Dr. Ranga and Krishanta sir. Thank you very much for inviting and also for the kind introduction. So it is a very interesting topic that has been allocated today. It is not just talking about sleep disorders. I think over the past few years, we have been talking about sleep and sleep disorders in many forums. And today we are going to take a step forward, and we are going to talk about the advances and the challenges in sleep medicine. So let me share my presentation. During the next half an hour or so, what I plan to do is I will be talking about sleep and how the sleep medicine is of much relevance to us in Sri Lanka in the South Asian region. Compared to our experience during the overseas training in UK, the cohort of patients with sleep disorders, especially the sleep apnea, are different when it comes to the Asian region. So I think it is very timely and it is important to have our own discussions and share our knowledge regarding these our sleep patients. So let me talk about the global burden of sleep disorders, concentrating on the Asian region, and then I will go straight ahead into the given topic. I have been asked to talk about the advances in sleep medicine, where I will talk about the diagnostic innovations, therapeutic advances, and of course, we are all heading for personalized and precision treatment. Then we will talk about the challenges in the sleep medicine, amidst all the advances that are coming, which are emerging in the world. What are the challenges that we face to keep abreast? So I'm sure this elite audience is quite competent and conversant on the basics of the sleep disorders we have. So I will not be going to talk about the steps in diagnosis, the sleep studies, the types of sleep studies, but we will go into a more interesting area where we'll talk about the advances and challenges in sleep medicine. So sleep is a complex neurobehavioral state, and there are a lot of changes in the brain and in the whole body during the sleep, where we sleep 1/3 of our day. When you take a 24 hours, it's 1/3 of our day, and it should be 1/3, so around 1/3 of our day, and then it comes to 1/3 of our life. And the depth, the duration, and the continuity, as well as the timing of the sleep, is regulated by a homeostatic process in the body and the circadian rhythm. The homeostatic process means how much of sleep, lack of sleep that has been accumulated through the day. So if you woke up at 4 o'clock in the morning today, by after 16 hours of wakefulness, then you are at a saturation point of being awake. That means it is, so then your homeostasis is shifting towards sleep. So this is out of the two, out of the circadian rhythm and the homeostatic process, which is the accumulated wakefulness, that is your bulk of being awake in the daytime, which pushes you to sleep, that will decide, that is one thing that will decide the depth, the duration, and the continuity. For example, if you have been taking naps during the day, then that will affect reduce the amount of accumulated wakefulness. Then you have the circadian rhythm, that is the body clock. In the hypothalamus, we have the suprachiasmatic nucleus. In there, we have the body clock, and that maintains the 24-hour rhythm. And this 24-hour rhythm, this body clock is batteried by, or gets its energy, or it runs by the sunlight. So the sunlight is called the main Zeitgeber. So that's a German term, which means that the sunlight is the main input, or the main thing that keeps the circadian rhythm running. The importance of the sunlight in running the circadian rhythm has been demonstrated where in research, in clinical trials, where people have spent days and days in caves where they have been deprived of sunlight, where their circadian rhythm is not maintained. Then they start to run a different, the different non-24-hour rhythm, which is inherent in their cells, starts running. So to maintain a 24-hour rhythm, that is to wake up in the morning and to go to sleep in the night, the circadian rhythm impacted by the sunlight is important. So why we sleep has been researched over many years, but of course, when people talk about why we sleep, we always have to ask ourselves, why are we awake? I'm not sure whether we are actually whether we actually have the answers to either properly. So sleep is critical to numerous biological functions that optimize the adaptation and functions through the body. It affects the the genetic mechanisms as well. And so the environmental and social factors influence the multiple dimensions of sleep, including the sleep duration, efficiency, regularity, and etc. During sleep, the body replenishes and repairs itself through cell and tissue growth. And currently, there is a lot of interest about this insufficient sleep. And as Krishanta sir mentioned during the introduction, there is increased risk of non-communicable diseases like gestational diabetes, obesity, diabetes, coronary artery disease, and cardiovascular mortality with insufficient sleep. Now, we are very familiar with this term, but let me highlight one study that really caught my attention, which really highlights that even a 1 hour lack of sleep, how it can affect the cardiovascular morbidity and mortality. We all know about the shift in the clock in the daylight for daylight saving time, which comes in the transition in the springtime in the Western countries. For example, if you were in the UK during the time when the spring transitions to summer, they do this daylight saving time where they shift the clock in 1 hour. And when there is the daylight saving time in the spring, there is a loss of 1 hour of sleep. And this loss of 1 hour of sleep and the impact of that has been studied and its impact on myocardial infarctions have been studied with the data from the Swedish Heart Registry. So the loss of even 1 hour of sleep during the transition to daylight saving time has been observed to have a significant increase in the risk of heart attacks over the next 3 days. So just 1 hour of sleep, where more than 1.5 billion people experience the DST transition, and it disturbs the circadian rhythm and sleep pattern for as long as 7 days. And it has been found that if this 1 hour shift can actually lead to an significant increase in myocardial infarctions over the next 3 days, and the reason being the likely mechanism is thought to be increased sympathetic activity, increased pro-inflammatory cytokines, which raise the cardiovascular risk. And actually, when they are in the autumn shift, where we get an additional 1 hour, there is somewhat slight reduction in the acute MIs. So this is, I think, shows that even we actually don't think much about a 1 hour shift, but or 1 hour lack of sleep. But this clearly demonstrates how important sufficient sleep is for our health. Insufficient and excessive sleep duration is important so they are important risk factors for mortality, and reduced sleep duration is associated with circulatory diseases, diabetes, impaired immune function, and neuropsychiatric disorders. So there have been a lot of studies to see why what is the connection between the insufficient sleep and this increased risk of non-communicable diseases, cardiovascular mortality. So few mechanisms are there, and the short sleep duration is related to reduced leptin levels and elevated ghrelin levels. And when there is elevated ghrelin levels, the ghrelin makes you eat. And there's the upregulation of appetite increases the incidence of obesity and diabetes. And the increased incidence of obesity itself, like a vicious cycle, as you know, will contribute to obstructive sleep apnea, which further reduces the quality of sleep. Restricted sleep is associated with impaired glucose tolerance, alterations in sympathetic nervous system activities, increased inflammatory markers, and elevated cortisol levels. All are associated with increased mortality risk. And also, when there is a short sleep duration, that means we are interfering with our own circadian rhythms, and there is dysregulation of the melatonin secretion. And when there is dysregulation of the melatonin secretion, that leads to increased high blood pressure and diabetes, because the even though the suprachiasmatic nucleus is the main biological clock, there are clocks in all cells in the body. So all the peripheral organs are affected when the main clock is affected. So as medical personnel, we from the time we are medical students, I think we have been playing with our sleep. And I think it's very important to know about this and try to get sufficient sleep as much as possible with our busy schedules. Now let's look at the global burden of sleep disorders. Insomnia is the commonest sleep disorder, and especially when people start aging, and especially in postmenopausal females, insomnia starts to hit in a considerable way. Acute insomnia, of course, many of us will have experienced acute insomnia. For example, if we are facing an interview, or if we are going for a exam, or even if we are getting ready for a function, it may affect a special function. We may experience insomnia, but it may last a few days only. But if it starts after being triggered by an event, if it persists for more than 3 months, then it's called chronic insomnia. And 10 to 20% of people are estimated to be affected by insomnia, and chronic insomnia as much as 6 to 10%. And sleep apnea, I'll show you a graph where we are talking about billions of people worldwide being affected. A restless leg syndrome, 5 to 10%. And the shift work, and we also have the shift work disorder and circadian rhythm disorders. Shift work disorders in healthcare workers, in the air crew, in the pilots, in the firefight workers. So, and the circadian rhythm disorders, especially in the teenage population, who have this problem of dealing with with devices. So there is apart from the increased cardiovascular mortality, there's impaired productivity and a global economic loss because of this problem of sleep disorders. So WHO shows that sleep disorders contribute to more than 7% of global deaths due to mental and neurological conditions. And obstructive sleep apnea and even insomnia are strongly associated with premature mortality. And again, the economic loss is estimated in billions. Now, from the global picture, when we look at our region, especially when it comes to obstructive sleep apnea, because I have specialized in respiratory medicine, the sleep apnea, I see mostly sleep apnea patients. And when it comes to sleep apnea, there is a higher prevalence in the Asian populations when it compared to the rest of the world. So this higher prevalence of obstructive sleep apnea in Asian populations are postulated to be due to unique craniofacial anatomy and the central obesity, despite having a lower BMI. Therefore, you may not suspect sleep apnea in patients who are not obese, and it may go undiagnosed. Actually, this is a striking feature, because when you work in a Western country, when a sleep apnea patient comes to your clinic, they can't sit on a chair. They're huge, but in our local setting, people who have been investigated, they bring files and files of investigations for fatigue and tiredness and uncontrolled high blood pressure, but they're not very obese. They may be overweight or even have normal BMI. And and these days people start thinking about obstructive sleep apnea, and surprisingly, a lot of people have sleep apnea. So let's look at it in more detail. So here, the global prevalence mapped out. So we are talking about millions here of the prevalence of obstructive sleep apnea. So we don't have for the Sri Lanka, we don't have, but Pakistan, AHI more than 42 million, India for 52 million. So these are sleepy people, millions of sleepy people with obstructive sleep apnea, walking around, especially driving, and driving about, putting themselves as well as the people around them at risk of things like road traffic accidents. So South Asians comprise 20% of the world population, therefore, and also there's a great variation in the Southeast Asians when it comes to diseases compared to the rest of the world. So why is that? So the key factors for increased prevalence of obstructive sleep apnea in Asians. One thing is, so there are two main factors. One thing is the craniofacial morphology. Asians are more likely to have craniofacial bone restrictions that predispose them to obstructive sleep apnea. The cranial base, Asians have a shorter cranial base with cranial base restriction. Therefore, if you have a little bit of fat deposition in the neck area, that can easily collapse and lead to sleep apnea. The mandibular plane hyoid bone distance. The Asians with sleep apnea have a longer mandibular plane hyoid bone distance. The maxilla is smaller and there's a retroposition mandible, and there is a shorter, steeper anterior cranial base. So most of these data are coming from large Indian studies, especially on X-rays and MRIs, and they have noted these changes in the Asians. So even if they are not obese, even if they have a normal BMI, and surprisingly, some people with severe sleep apnea have BMIs of 21, 22, 23, and they have severe sleep apnea, and this can be mainly attributed to this craniofacial morphology, which is, well, unfortunate because we can't do anything about it. And then the other factor that increases the prevalence of sleep apnea in Asians is the central obesity despite lower BMI. So when compared to the Western populations, we are apples and pears, where we have central obesity and 4 sticks stuck on the apple or the pear, where that is what our phenotype is. We have a lot of, so people will have a fairly a normal or near normal BMI. They appear to be not fat. They appear to be normal weight, but when you actually look at them, there's a lot of central obesity. And when we talk about central obesity, it is not only the abdominal fat, it is also the neck fat, and also fat behind the tongue, which the tongue fat, which contributes to sleep apnea. So 70%, these are some of the studies. So BMI is not an accurate indicator of obesity among Asian populations, even though the Asians are at high risk of obesity-related illnesses. So the obesity-related illnesses of cardiovascular diseases, diabetes, and the metabolic syndrome is rampant in Asia, despite, compared to the Western populations, compared to the whites, we have a lower BMI. So measuring abdominal fat is particularly critical for Asians, and we seem to have 3 to 5% higher body fat percentage compared to the European whites. And this higher intra-abdominal fat may contribute to larger upper airway soft tissues and increase tongue fat, which will contribute to sleep apnea. Right. Now, with this background, let's move on to the advances in sleep medicine. So we are so this is the background to say how important talking about sleep medicine is. We know that there are several types of sleep disorders according to the ICSD-3 classification. We have the insomnia, the sleep-related breathing disorders, the circadian rhythm disorders, and the hypersomnolence disorders, as well as the restless leg syndrome. And I'm sure we know about this, so I'm not going to talk about the diagnostics and the basics of these. Let's go straight into the advances in the in these conditions. So when it comes to diagnosis of sleep conditions, the traditional gold standard is the polysomnography, and still it is the gold standard despite lots of advances or lots of devices or lots of technology is in the pipeline as for diagnostics, but still the polysomnography is the gold standard for diagnosing sleep disorders. The problem with the polysomnogram, as you know, is that the patient has to come to the hospital, and it is expensive and it is labor intensive. So the patient, there has to be an on-site technician, and the score data or the stored data, the monitored data, there's a lot of data that is being recorded and that has to be scored. At the moment, there are no auto scoring devices that are still better than the manual scoring. So we have the EEG, the electrooculogram, electromyogram, the ECG, the respiratory effort, oxygen saturation. So all this data is being recorded, and the patient has to wear the device. And sometimes patients are a little hesitant. They ask, will I be able to fall asleep with all this on my head? However, surprisingly, we rarely have to repeat a polysomnogram due to lack of sleep. There are maybe one, occasionally you have, but it's not common. Even despite having this anticipation of how to fall asleep with this polysomnography device on, people still do fall asleep. And especially these are people, usually it is for people with sleep disorders, especially sleep apnea patients with sleep apnea fall asleep very easily, despite the initial anticipation. Sometimes you find them falling asleep while while sticking all those ECG and EEG leads. They fall asleep, so they are that sleepy when it comes to sleep apnea. However, now over the past decades, this problem of coming to the hospital and having a sleep study, having to sleep in an unfamiliar environment, have been tried to be overcome by the home sleep apnea test. Now, the home sleep apnea test is something that is available here as well, and where the device is worn on the chest, and we have the nasal pressure and the nasal flow, and the patient either wears it at home or wears it at a center and goes home and sleeps. So it is more accessible, lower cost, and patient feels more comfortable. However, you have to be very careful when you select which type of patients you are going to give a home sleep apnea test, and I will talk about it in a little while. How to choose, because especially in our setting, with patients who have who don't have the proper phenotype of obstructive sleep apnea or moderate to severe, you have to be careful when you give a home sleep apnea test, especially because now these tests are available in state sector clinics, but sometimes it's not very freely available, and there will be a waiting list, and if you have to repeat a test, that can be cumbersome and costly to the patient as well as the hospital. So you have to select carefully. There are a lot of wearables in the market. People come and show you, patients come and show you. There are smart watches, rings, headbands, Fitbits. and they come and show you, they tell you my REM sleep is like this, my deep sleep is like this, my watch tells me my sleep is not good. Most of the time they track the heart because it's worn on the wrist. They can track the heart rate variability, oxygen saturation, and they mostly deduct or mostly determine the stage of sleep by movement because they have inbuilt accelerometers. So they kind of give an overview of the sleep behavior of a patient. But when it comes to the accuracy, you still can't replace the hospital or the medical home sleep apnea test or the polysomnography. There are some FDA-cleared devices for the obstructive sleep apnea detection, but to start treatment, you have to confirm with your in-house device, in-house tests. So when people come and talk about these their findings and their concerns, it is important to realize that these are a cohort of people who are concerned and who want to improve their sleep health. So it is good. It is in a way good that they want to know about their sleep and they want to improve their sleep, and that is a pathway, or it's a door that we can open to talk about them about good sleep hygiene, identify their sleep malpractices, and then if there are sleep disorders, we can always ask them to confirm if there's any abnormality shown in their, if they come up with any abnormality detected in their wearables, we can confirm by a polysomnogram. But we have to tell them that we are not going to start treatment based on these wearable devices. So accuracy of these devices can vary depending on the specific model, the population being studied, and the severity of the sleep disorders. The problem is these portable monitors tend to underestimate the apnea-hypoapnea index, especially in patients with mild obstructive sleep apnea, and may miss cases of upper airway resistance syndrome. So that is the problem when you do a home sleep apnea test as well, because you don't have the EEG when you do the home sleep apnea test. And when you put the EEG, we detect the RERAs, or respiratory effort-related arousals. So the respiratory effort-related arousals, which are mainly due to the upper airway resistance, can be missed, and you can have a falsely normal apnea-hypoapnea index in a patient who has significant sleep apnea. So the current consensus is these monitoring devices are sufficiently accurate for diagnosing sleep apnea in patients with a high pretest probability of the disorder and don't have comorbidities. And this is backed up by the American Academy of Sleep Medicine. They also recommend the home sleep apnea test as an acceptable alternative to polysomnogram for diagnosing sleep apnea in uncomplicated adult patients with symptoms and signs of moderate to severe OSA. So you have an obese patient who have the typical symptoms of obstructive sleep apnea and the stop bank score is sky high. Then you can go for a home sleep apnea test because you know even without doing the test they have sleep apnea. But the borderline cases where they are normal BMI or overweight and you're not sure whether it is whether this is whether it is sleep apnea or not, then it is better to go for a polysomnogram. Otherwise, you have to ask the patient to come back again for a polysomnogram, which they usually don't comply with, because one test has said it is okay and they go and they start to rely on it. So I have already talked about it. So these wearables are important to raise awareness about sleep health and to identify individuals who may benefit from further sleep evaluation. Recently, there is this WatchPat, or the peripheral arterial tonometry device that is commercially available. And even during my overseas training some time ago, the WatchPat was the one that the device that was more FDA approved and was being used more commercially, and it was more or less better than the home sleep apnea test in terms of accuracy. So what the watchpad does is it monitors the peripheral arterial the stiffness, as well as the oxygen saturation, as well as the heart rate, and the physics behind the watchpad actually can determine the stage of the patient by the detection of the tonometry. Apart from the watchpad, there are other things such as mandibular movement sensors, which are still not in the market. But apart from sleep apnea, for narcolepsy, the orexin or the hypocretin level is being used as a biomarker, and there are other inflammatory markers and cortisol rhythms, that is, the circadian rhythm has been observed to detect the circadian rhythm disorders. So those are available still at research level. Then MRI studies and PET studies are also, especially for REM sleep behavior disorder, the MRI and the PET studies being used still at research level. Then this artificial intelligence, we are automated scoring to replace the polysomnogram is being studied, and there are devices which are being developed where artificial intelligence is being trained to identify and come up with the algorithm to replace the manual scoring. And when this comes out, actually it will reduce the inter-scorer variability as well, and it will make our life very easy, because scoring a polysomnogram takes a long time. Along with the COVID era, we have the telemedicine being integrated into sleep medicine, and actually sleep medicine is one field where you can do a remote consultation successfully, and not only explain the diagnostics to the patient, but also like the therapeutic monitoring, the treatment monitoring can be done. For example, if the patients are on CPAP devices, you can do the monitoring and the consultation through a telemedicine and without a physical consultation. So that is one field, that is one area that is successful. When it comes to conditions like narcolepsy and circadian rhythm disorders, genetic studies are playing an important role. In narcolepsy, the genetic identification of HLA-DQB1, and in circadian disorders, the gene PER3 have been implied for the development of this disease, and they are being checked, and salivary melatonin testing is also being checked. So these are done at research level, and some of the neurology teams are actually liaising with overseas neurology teams to check our patients' genetic polymorphisms as well. Moving on to the therapeutic innovations. So that is the second part. So we have the advances in diagnostics and the advances in the therapeutics. So in obstructive sleep apnea, there are so the main treatment, or the first line treatment, is the CPAP therapy. First-line therapy is the CPAP, and in the CPAP, sometimes the patients who are given a CPAP device may have difficulty in tolerating it. So when you put a patient on a CPAP device, it is very important to actually follow this patient up, because you will need to titrate the pressure and do the mask adjustment, which is necessary for good compliance. So you can't just prescribe a CPAP device and ask the patient to use it, but you have to get down the patient just like you get your other long-term disease patients like diabetes or high blood pressure. You have to ask them to come for routine follow-ups and check the devices for their compliance and whether they have any problems. So now to mitigate the problem of these, you have the auto PAP and the fixed PAP that is for patients, but the next generation ones are the auto titrating positive airway pressures, where the device can detect the patient's obstruction and give the adequate pressure depending on the obstruction. So, and there are other comfort settings that are being built, such as the expiratory pressure relief, where people complain that they find it difficult to breathe out against the CPAP device. So there are these comfort features which are being built. And the pattern of using the CPAP device is now being stored as data storage in the CPAP device. So when the patient brings the CPAP device, you can see whether their CPAP or the sleep apnea is controlled, what is their residual AHI, what is the mask leak, what are the pressure settings, and all can be adjusted. Apart from the CPAP therapy, the novel treatments are hypoglossal nerve stimulation. Hypoglossal nerve stimulation is a validated treatment for obstructive sleep apnea in patients who can't tolerate the CPAP device. So the hypoglossal nerve stimulation, what it does is it's actually a mini surgery where this device is placed to stimulate the hypoglossal nerve so that the tongue maintains a tone and the tongue collapse is prevented. And there's the smart bedroom concept. I hope you can. The smart bed. Then now when it comes to sleep medicine, there are a lot of devices, there are a lot of gadgets which have to be worn. So there's a lot of interest in developing these non-contact devices. There are certain devices that are kept under the mattress to understand the respiratory rate and body movements to predict the sleep disorder. So a lot of in a lot of diagnostic equipment as well as therapeutic innovations. There's a smart bedroom concept where the ambient temperature of the room is being checked to identify what is the best temperature for that person to sleep. The humidity and the light level is being checked, and also along with the sleep quality. Then, apart from the CPAP devices and apart from the smart bedroom, where a lot of devices are being innovations are coming up to reduce the contact devices in the body. Apart from that, we also have the oral appliance or the mandibular advancement device. So people who can't tolerate CPAP device, we do have the mandibular advancement device where we make the custom-made appliance. The lower jaw is shifted forward, and the mouth imprint is taken. And here in Sri Lanka, in people who can't tolerate CPAP device, we along with the OMF surgical team in the National Dental Hospital, we refer patients to make the custom-made mandibular advancement device. There is a lot of interest in the semaglutide or the GLP-1 receptor agonist, which promotes weight loss. And in patients with obstructive sleep apnea who have increased weight, who are due to obesity, this has a place. But apart from that, what is important for us is the newer medication, the atomoxetine, the oxybutynin atomoxetine combination that is in the stage, in the clinical trials, which show a lot of promise for the Asians. I will talk about that in a little while. So obstructive sleep apnea, causes increased ghrelin, which increases obesity, and obesity itself increases obstructive sleep apnea. So it is a vicious cycle. Now, as obstructive sleep apnea can be found in non-obese and underweight individuals, so especially in the Asian setting, the recent clinical trial has shown a lot of promise in the drug oxybutynin atomoxetine, where it improves the upper airway collapsibility in the Asians who have a narrow craniofacial abnormality. Where the airway collapsibility has to be addressed, and this oxybutynin atomoxetine is showing a lot of promise, and hopefully if it comes to a commercial level, this will pave the way for people to have another option instead of the CPAP device, which will be, I think, a huge relief, especially when it comes to patient comfort and cost. So in the other sleep disorders, there are newer medications like in insomnia. The orexin is the wake promoting hormone, so orexin antagonist. Now we are using a lot of, so for insomnia treatment, actually the cognitive behavioral therapy is the main treatment, not medications. But in insomnia, most of the time benzodiazepines are being used. However, this orexin antagonist, orexin is a wake promoting hormone, and orexin antagonists like suvorexant are actually coming up in the market. And then digital cognitive behavioral therapy, where you can use your apps to improve your sleep health. And then melatonin receptor agonists for circadian rhythm disorders like Rameltian and Tasimeltian are also available in the Western countries to treat these disorders. For narcolepsy, we usually treat with the amphetamines. There are still there are promising medications like the newer agents is the wake promoting hormone solriamfetol. The solriamfetol is the one that is being talked about a lot these days with regards to the treatment of narcolepsy, especially in the USA. The solriamfetol is a dopamine norepinephrine reuptake inhibitor. Apart from that, now apart from the amphetamines, the pitolisant, which is a H3 receptor agonist, is still very expensive in the Western countries and are reserved for people who are not improving or not tolerating the amphetamines or the modafinil. So as an alternative, the pitolisant is actually commercially available for the treatment of these hypersomnolent disorders. When it comes to REM sleep disorders, we don't have much. We still have the clonazepam and the melatonin, and still there's still research is underway. And restless leg syndrome, we have the gabapentin and the pregabalin. There's nothing new to report about. Circadian rhythm disorders, I told you about the melatonin antagonists, the tasimeltium, and well, there are also research to see whether transcranial current stimulation can enhance the quality of sleep. So these are at this sleep at the research level. So the precision medicine is being talked about a lot these days, where individualized treatment based on the genetic profile, based on the phenotype of the patient. So in sleep medicine also, those are still in the research level, but I think over time it will come. So when it comes to the challenges, so all these diagnostics are fine, but the challenges remain, especially in our part of the world. The accessibility to the basic home sleep apnea test or polysomnogram is still very expensive, not available everywhere in the country, and there is a long waiting list. Apart from that, the limitations of the over-reliance of the apnea-hypoapnea index, that may not be enough when it comes to our population. So we may have to do polysomnogram if the patient comes with who are not very obese or just overweight or obese. We may have to go for the full polysomnogram. So those are the limitations. We don't have wearables. We'll do, but not in a wide way. Awareness about sleep disorders. Currently, the awareness is increasing slowly, but still, I don't think we are reaching all communities. And sometimes people may not know who to go and tell their sleep problem to. Uh, and a lot of the cardiac condition, a lot of medical diseases have insurance coverage, but when it comes to sleep medicine, uh, people find it very difficult to get their sleep investigations or their sleep treatment covered by insurance, and there are no reimbursement systems. So that is another problem. Whereas when it comes to other heart diseases or other complicated metabolic conditions, you can claim by insurance. But when it comes to sleep disorders, these diagnostics and the treatment is not covered by insurance, and these are expensive things. And if there is a insurance coverage, I think we can access, we can give the diagnostic services and the therapeutic services to much more. And well, it is Asia, limitations in Asia. There are cultural factors, and when there's urbanization, obesity, diabetes, we do have to improve our diagnostic abilities. Well, we still they are not in our national health policies, the sleep medicine, and we lack normative data as well. So these I talked about how expensive these are and the therapeutic barriers. Newer pharmacological therapies are not freely available to us. Lack of trained staff. So these are the challenges and the limitations. And I think in years to come, well, when we talk about the advances and the future, there will be a significant place for telemedicine in sleep medicine. There will be remote sleep studies available, wearable devices that can be taken and done at home, where consultations and prescription of therapy as well as monitoring therapy can be done through telemedicine. And of course, artificial intelligence, the AI-generated algorithms will give a better input to diagnostics in the polysomnogram to reduce the time that is taken at the moment for scoring of polysomnography. Yeah. So right. However, even though these lot of technologies are in the pipeline, they must be implemented carefully. And just because AI tells you it may not be correct, there is an important component of human clinical judgment in medicine, which AI cannot replace. So however much there are technological advances, it always has to be coupled with the human clinical judgment. When it comes to sleep medicine and I think all medicine disciplines as a whole. So thank you very much for listening, and if there are any questions, I will be happy to answer to my knowledge. And apologies again for the unexpected disturbance.
Thank you, Dr. Ruwanthi, for your excellent overview. Shall we take up the questions?
Yeah.
Yeah. So the first question is OSA is becoming a major risk factor for cardiovascular comorbidities in SL. Do you have any local data, and what interventions are needed to overcome this burden?
Well, I can't remember offhand, but there are certain small studies which are published in local journals and BMC. They well done at small level. Yes, so there is a link between sleep apnea and cardiovascular diseases, but the actual burden, we need more data, and what interventions. I think being aware, and we have to start screening especially in clinics where how these patients are. For example, the diabetic clinics, the heart failure clinics, the kidney disease clinics. Those are the places that these patients are there. We are not picking them up, so we have to, I think, increase the diagnostic rate. Having said that, once we pick them up, then we also again we face the limitation of the sleep studies. I think the way is to mainly increase the diagnostics. So they increase the diagnosis, picking up the patients, and then when we treat them, that will reduce their cardiovascular burden, which comes from this, especially the sleep apnea, from intermittent hypoxia in the night, because it is that intermittent hypoxia in the night in sleep apnea which leads to the endothelial dysfunction, and the increased inflammation. But yeah, we need more studies, and we need to increase our services to the other clinics, especially the diabetes and the kidney and the heart cardiac clinics. I would like to know your input as well with regards to this, because I think it is a common problem and we need to improve our services.
If craniofacial morphology is the cause for sleep apnea, is there a place for plastic surgery or MEF surgery to improve the quality of life?
Yeah, so the craniofacial morphology is one of the causes. The other causes, the aging itself increases the risk of sleep apnea, the male gender, and the obesity. Apart from that, we have to look for hypothyroidism, acromegaly, underlying endocrine disorders which can lead to obstructive sleep apnea. But when it comes to craniofacial morphology, you can't do so. One thing is you can't do surgeries. These are mutilating surgeries. So there is a place for surgery in certain sleep apnea patients where there is significant retronathia. Now, the place for surgery in obstructive sleep apnea, there are various surgeries that are described. The PPP, where the uvulopalatoplasty, where the small palate is being lifted up and created more space. But the problem with these certain surgeries are that the correction is at only one level, but in sleep apnea, the collapsibility happens at various levels, at retroglossal, retropalatal. So you can't do surgeries at each level. So the main surgery that actually corrects obstructive sleep apnea, which is related to a structural anomaly, is the maxillomandibular advancement surgery, which is a major surgery where you have to displace or take out the full lower mandible and fix it forward. So it is done but it is done very uncommonly, and you can have you can have complications. It's a major surgery. So and it's not an easy one, but in certain patients when there is significant visible retronathia, or the retraction of the jawline, where even with sleep apnea they may not CPAP machine they may not correct, then you can do the main surgeries, the MMA, the mandibular maxillary advancement surgery. But you can't ask all these people to undergo MMAs just because they have sleep apnea. Therefore, the first line treatment is the CPAP therapy. So the patient use the CPAP in the night, and their sleep apnea is corrected on that night, and so they have to continue using it. And when they have a good compliance, when they're going for breaks like holidays, 1 or 2 days, it's all right for them not to use, because they can have it has a carry-on effect for a few days, but other than that, they have to use it every night.
Okay, I think this needs a diplomatic answer. When we come across patients with OSA and associated sleep problems in our primary care, to whom should we refer? Is it respiratory physician or ENT surgeon?
I think think the first thing is to do a screening questionnaire.
Yeah.
So if there are patients who use suspect sleep apnea, I think it's very important to keep eyes and ears open to catch or to throw the net and catch these sleep apnea patients to be treated because of the high burden of the cardiovascular diseases. So you can do the stop bank score. It is very simple. There are just 8 questions where you ask the sex, that is the male gender, the tiredness, the snoring, the tiredness, the obstructions or the visible apneas, high blood pressure, BMI more than 30, age more than 50, neck circumference more than 16 collar size, and gender that is the male. So if you fulfill 3 of that 8 of the stop bank score, then that person is at high risk of sleep apnea. So the next thing, when you have this high suspicion of sleep apnea, is to refer for a sleep study. So sleep studies are available through respiratory clinics identified in Jaffna or Ampara or Kurunangala or wherever you do get the sleep studies. The level 3 sleep study is available, as well as the level 1 sleep study. And the level 1 sleep studies are also available in the neurology clinics. For the sleep apnea testing, first thing is to get a sleep study done, currently available through respiratory clinics. And once the patient has a diagnosis, then the management has to be discussed, depending on what we find and what the diagnosis is.
Is the snoring of a child needs to be assessed?
Yeah. Snoring of a child, mainly that is because of the soft tissues, that is the adenotonsillar enlargement. Children who have recurrent upper respiratory tract infections will have swelling of their adenotonsils. So snoring per se in that child may not be sleep apnea. What we have to do is, well, you have to look at the mouth and see whether they are kissing tonsils. That means they are very enlarged and they are blocking the whole throat. Actually, this tonsil enlargement, this will require a pediatric ENT assessment. What you have to find out is it just snoring, or is there any other condition like upper airway obstruction? Like these children may have nasal polyps, they can have allergic rhinitis, which can be mistaken for snoring. And the other thing is whether it is snoring due to sleep apnea, because if it is sleep apnea, they may demonstrate signs during the daytime, which can be a little different from the adults. The adults will have, they will complain of headache, they will complain of tiredness, sleepiness. But in children, actually, they can come with hyperexcitability. They may come, you may actually diagnose them as ADHD or hyperexcitability. So if they are lacking concentration, they are irritable during the daytime. So you have to look out for these symptoms to suspect sleep apnea in a patient. So if there is a child who is snoring and who is struggling to sleep in the night with sleep fragmentation, and maybe, well, even nocturia, it's very difficult to determine whether the nocturia is due to sleep apnea or is it a normal occurrence in a child. So you can do a sleep study. So sleep studies, pediatric sleep studies are done at LRH, and it is done through, I think, the ENT team. So once they are diagnosed in pediatrics, not like in adult medicine, the moderate to severe sleep apnea are treated with tonsillar resection. However, now this is not a general statement. The cases, the pediatric patients they are evaluated properly, and they are picked up. Or everybody who has sleep apnea don't get this tonsillar surgery. They are evaluated, and the proper treatment is determined by the specialist. One thing more I wanted to, yes, in the pediatric patients, the scoring criteria is also very different to adult sleep apnea scoring criteria. So when you do a sleep study for pediatrics, we have to couple it with a capnograph, because in pediatrics, even one apnea AHI of 1 is enough to call it significant, and we couple it with the capnogram for scoring. So you need that as well for pediatrics.
And Dr. Ruwanthi, on behalf of our fraternity, can you kindly let us know what are the state-run centers that have sleep labs so that we can refer the patients?
So in the state sector, the central chest in Colombo, the central chest clinic in the Colombo South. I think almost all teaching hospitals around the island have the sleep study facility. I think if you refer, so that patients can get them done through the
State hospitals.
yeah.
Okay.
Even when I was in Navalpiti, it was there. So even Ampara has, so Badulla has, so around the island, I think most of it. The problem with the sleep laboratories is these small device. They are these small gadgets, these leads. These consumable expenditure is quite high, and because the patient has to sleep with it, if you damage a part, it's very difficult to replace it because even the small parts are very costly. We are talking about lakhs. So so sometimes they may not be functional for a period of time, but most of the time around the island. These facilities available for patients to come and get it done.
Yeah. Oh, this is a nice question. What are the methods that we can fall asleep fast?
Why do you want to fall asleep fast? Is it insomnia management or
I think it's good.
yeah. So actually, I think it opens the discussion into another area
Another area.
because then we have to talk about sleep hygiene.
Hmm.
Actually, sleep hygiene is not only confined to the night. Sleep hygiene is a full day and night routine. So the main thing starts from maintaining a routine where you have a set sleep time, a set wake up time, irrespective of the time of the week. So now sometimes we tend to oversleep during the weekends. Well, maybe not us, but for people who have the luxury of doing so. But the recommendation is to maintain a set routine irrespective of the day of the week. So having a set routine, and then half an hour before you're going to bed, you have to stop everything, including your devices. So your devices have to be stopped half an hour before. Moderate caffeine, that is your teas, coffees, fizzy drinks, hot chocolates, have to be in moderation. No smoking and alcohol in the given limits only. Smoking is quite detrimental to sleep and can cause insomnia, which can be very difficult to treat. And then apart from that, you have to maintain your hygiene. You have to have a good bedroom setup, and then good exercise and nutrition also contribute to a good sleep. Exercise, plenty of sunlight in the morning is important for good sleep. I mean, sunlight has its own benefits, but plenty of sunlight in the morning hours, especially in the first 3 hours after waking up, has an important impact in good sleep quality. So especially in elderly patients they keep their doors shut, and they have poor sleep. So ask them to open the windows, open the curtains in the morning. And the best time to exercise for a good sleep is the first 3 hours in the morning. It can be just a light run or a jog or just seated exercise. So these things and so good nutrition all help. However, if it is the insomnia management that we are talking about, then that is a separate thing, because insomnia needs cognitive behavioral therapy for insomnia, or CBTI, which is the next step from maintaining good sleep hygiene practices. I hope it answers that question.
Yeah, thank you. And since most of patients in Sri Lanka can't afford CPAP, when it comes to weight loss, how much weight loss should be the target? And the second part of that question is, in normal BMI patients, what are the management options available in Sri Lankan setup?
Yeah, so the CPAP device is quite expensive. But actually, when you do look at the long run, looking at the now untreated obstructive sleep apnea patients spend a lot, especially that is what we are trying to drill into the insurance people also, because now if you treat obstructive sleep apnea, then you prevent a lot of cardiovascular morbidity, and that itself is a saving. So that's a saving to the patient as well as the health sector. So they save on the hospitalizations, they save on procedures, they save on traveling. So even though this device seems to be expensive, I think in the long run it is cost effective. Well, of course, I completely agree that it is expensive. There's no doubt about it. But in the long run, it may be cost effective. And the other thing is, this device is just a one-off buy. So once you buy it, you use the CPAP device is used for 10 to 15 years. However, the masks can be used for about 1.5 years with good use, but the the consumables can be quite expensive as well. So I think the question is, in the event of, so when you the problem with sleep apnea is, yes, you can. You have to refer for weight reduction. I usually get the input of the nutritionist to give an input regarding the weight management, because when people just stop eating, then they become malnourished. They become obese. They are obese, but they are malnourished. So they have to get proper nutritionist advice, and weight reduction, even a few kilos of shifting the weight because of the reduction in the fat deposition, can help in the improvement of the sleep apnea. And even, but despite having said that, it is very difficult to, it may be quite challenging to reduce the weight when the patient has sleep apnea, because as I told before, sleep apnea increases ghrelin levels, which in turn increases the weight of the patient. So once you treat the sleep apnea, it is easier to lose the weight than before treatment. So again, we are go back to square one. So I think I think the way forward is maybe to have our own devices, to manufacture or produce our own wearables, the consumables such as the filters, the tubes, and the masks. If we can produce our own, I think that will have a remarkable impact on the cost. I think the second part of the question was, Dr. Ram?
Second part was actually in normal BMI patients, what is
Yes.
the management options with what are the management options you are going to set
So
up?
normal, yes. So it's a normal BMI patient. Well, you can't talk about weight reduction. So in the normal BMI patient, the options, well, if the CPAP is the first line treatment, but if the CPAP is not enough, if the CPAP is not affordable, then the other options are the mandibular advancement device. So the commercially available mandibular advancement device, which is not available here, but in other countries, there it's quite cheap. Where you put it to boiling water and you heat it, and it takes the mold of the mouth, and then you can go, if the patient tolerates that, then we can go for a custom made device. And then so you have the mandibular advancement device, and other options are they can do surgery if they are not tolerant of the CPAP device. But in these patients, it is mainly the CPAP therapy. So when it comes to sleep apnea, the sleep app therapy is recommended for patients with moderate to severe degree, but mild obstructive sleep apnea, or patients with snoring without sleep apnea. We don't have to give the CPAP device. Actually, we can try the mandibular advancement device for the management of snoring. So those are the treatment options.
When it comes to sleep, break it down to 6 hours at night and 1 hour in the evening hours. Is it good? Or what matters? Or what matters actually total time or quality of sleep?
Yes, so that is another question, whether you need 4 hours of sleep. Can I do 2 in the afternoon and 5 in the night?
Right,
So,
right.
yeah, so actually, studies have shown that we have to go through that number of sleep cycles in the night. So so we go through about 5 to 6 sleep cycles in the natural sleep. That one sleep cycle is about 1.5 hours. So 5 to 6 sleep cycles are the normal sleep in the night. So these amount of sleep cycles are required for the body's metabolism or the physiological functions that happen in the night in sleep. So curtailing that amount and having 2 hours in the daytime has not been proven, or there is no evidence to say that that is good. However, a daytime nap in itself, usually what we recommend is about 40 minutes in the post lunch, in the first 2 hours after lunch. Post lunch period, you can have about a 40-minute nap. That is all right, but there is no backup for us to say that you can break your 7 hours into chunks and that is good. The main point there is that you need your 5 to 6 hours of sleep cycles, which because in those 5 to 6 sleep cycles in the night, the brain reconstitution, or the brain gets rid of some of the beta amyloids and all the toxic material, and also the memory consolidation, where the memory that is stored in the transient memory goes and deposits in the deep memory or the cortical centers. So those things are happening during the sleep. So so I don't have any backup to say that you can actually break it up. What is recommended is the number of hours that you need. There is no such thing as 6 hours, 7 hours, 8 hours, 9 hours, but you have to find out. You allow yourself to naturally fall asleep for about 3 days without an alarm clock to wake up, and then you can find out what is your requirements. For example, so I need 7 hours, so somebody else might need 6.5, somebody else might need 8. So you have to find out what's your biological clock is like.
In the absence of any more questions, I thank Dr. Ruwanthi Jayasekera for her excellent overview on sleep disorders. On behalf of the Sri Lanka College of Internal Medicine and the Council, I thank you again for accepting our invitation to enhance the knowledge and practices of our practicing physicians. Thank you, Dr. Ruwanthi.
Thank you very much. I greatly appreciate the opportunity given to talk to it in your elite forum.
Thank you. And I thank the audience, and let's join in September with the September chapter of Therapeutic Forum. Good night.